All right, good afternoon, everyone. This is the Task Force on Affordable Accessible Healthcare, December 15th, and we're resuming our meeting this afternoon. And we have with us our consultants from Health Systems Transformation. Joshua, why don't you introduce the folks from Clarify Health Solutions for us?
Sure. Is Chuck on?
Chuck is on.
Okay. Right. And so we have Chuck on from Clarify Health. HST and Clarify have had a number of conversations to hone a presentation for you that will briefly introduce Clarify Health, talk about their capabilities in just a handful of slides, and then they're going to do a live demo of data. Using Vermont data, in fact, from multi-sources to show what the art of the possible might look like. I hope that will help us to think about the presentations that we had this morning and how they connect together, how the dots connect, and then help us to lead into the conversation this afternoon on the next two options. So, Chuck?
Fantastic. Thanks, Josh. And Josh, should I be presenting the slides?
I think Julie's going to be able to.
Oh, okay.
No, or you can, Chuck. Go ahead. Yeah,
Do you
sure.
have them? Do you have them, Chuck?
I do have them, if that's what makes sense.
Yeah, why don't you do that?
Just one moment while I get that set up. While I do that, very nice to meet everyone. I hope you can hear me okay. Chuck Furyk, I am a Vice President of Product Development here at Clarify. Very excited to show you our platform today in hopes that we can better understand how you can get more equitable and inclusive care for all Vermonters across the state. I'm going to walk through just a few slides to sort of set us up and give us context. And then from there, actually move into the software and hope you can envision how we can actually use this software to create the results that you're looking for to better manage the patient populations that you serve. Is everyone able to hear me okay and see my screen?
Yes.
Hear you well.
Awesome. Thank you. Just one moment. Somebody's vacuuming outside my door. I apologize. Okay. With that fun dramatic entrance, let me reshare. So a bit just on who Clarify is. We share the same mission that you all do in terms of making sure that we can provide equitable and care for all patients across the country. We as an organization have been around for over 6 years, and we serve customers across the health plan, provider, and life sciences space, as well as unique organizations like yourselves today. The way that we do that is building a set of products that sit on top of a data platform that we built that we believe is industry leading. We as Clarify have a data set of over 300 million lives across the country. That is a combination of all 100% of the Medicare fee-for-service lives at an individual patient level. And we combine that data with an additional 250 million lives worth of commercial data as well. The majority of that data is longitudinal in nature, meaning that we have at least 1 year's worth of claims data for all of the patients that are in our database, which allows us to look at their full journey of care and understand everything from that initial visit on January 1st to a surgery that happens on December 31st, all of the care provisioned during that time period. In addition to that claims data, which allows us to look at the clinical performance of providers and the clinical needs of your patients, we also marry that data with social determinants and health data. And we bring in over 400 different variables at an individual patient level, including things like access to transportation, living alone, and household stability, and then tokenize that with our claims data to get the most full picture into a patient population as possible. That data is all tokenized and secure, meaning that we are high trust and HIPAA compliant, so that data is always secured and locked away in a safe encrypted fashion so that it can't be broken down. But it allows us to link all those data sets across one another in order to make sure that we see that entire patient journey. And the way that we're able to do that is we have a team that actually comes from the healthcare expertise side of the world. One of our co-founders was a former senior partner at McKinsey, focused on their healthcare business. And our other co-founder actually came from the banking industry. So think high frequency trading and hedge fund management. And we've applied that set of data capabilities to healthcare. And that's resulted in over 10 patents in the way that we clean our data, we normalize it, and we produce insights into patient needs and provider performance. So beyond that context, quickly, this is just a sample of the types of social and behavioral determinants data that we're able to pull into from the software. So at the individual patient level, as you begin to define different cohorts of patients that you want to look at with appropriate interventions, we can break them down by these different categories, looking at income level, age and demographics, gender and ethnicity, as well as some of those other factors that I mentioned that we have determined actually have a high impact on healthcare outcomes. Are you a homeowner or a renter? Is your address stable? How long have you lived somewhere? Do you have a car? There's also other features that we get, such as gym membership, where you buy your coffee, but those things are not as important as the factors that our clinical research team have determined actually correlate with healthcare outcomes, in which we can surface through our software and in the insights we provide. The way that we do that, and hopefully you'll see this in the software in a moment, is being able to look across an entire market, and in this case, Vermont, understand the clinical and social needs of the patients that live in that market and how well their care is being managed. Is there excess utilization happening? Is there more readmission rates than we would expect? And are those readmission rates falling predominantly with a certain type of population? Maybe your lower income African Americans are having worse outcomes than a different set of cohorts. And we're able to precisely pinpoint the exact patients of who those are to define the right interventions. We can also look down at the individual physician level and see the care providers that are actually responsible for caring for these patients and how well they're doing from that perspective. And then lastly, with all of that resulting in the patient list that is the patients that actually need intervention and need the higher quality care that we're looking to provide for all Vermonters. One last slide on how we do that. Clarify is unique in the way that we take our data, which is that 300 million live training data set, and use patient level case mix adjustment, meaning accounting for the fact that some patients are sicker than others and some patients have more social determinants of health, and create an expected value of performance or cost for every one of those patients across. We then compare that actual cost or that expected cost, the expected cost represented by this blue diamond here, and we compare that to what actually happened. So in this case, if we would predict your readmission rate should be 2% and the readmission rate was actually 15%, we can identify then what are the drivers of that unwarranted clinical variation and why perhaps these patients are having worse outcomes than we would expect them to. We do that at every single patient level. And so when I jump into the software in a moment, you can actually see how we're using that in practice. As I move over to the software, any questions so far?
Yes. So going back to the data collection process where you have it's on slide 24 in our packet, where you have available categories and attributes, and how is all of this data collected? If you're using, I'm trying to look and see where the data comes from. If it's from a state database or a physician database, how is all this information collected?
Yeah, so we do that in a number of ways. So for our claims data, we get that from either CMS itself, they provide us the claims data for the Medicare data, or directly from different clearinghouses and payer direct sources or health plan direct sources that are able to provide us that data on that secure tokenized basis. In the case of we had the opportunity to work with Vermont, I believe there's all payer claims database or others from where we could get that individual claims level of data. For the social determinants of health data, we work with other third parties. Think of the types of organizations that are doing like a credit risk rating when you're getting a loan on a house or looking to buy a car that have resale rights on those data at the individual patient level. And then our tokenization process, is that's sort of a standardization term that we use, allows us to match those social determinants data to that claims data to get a full picture into the needs of the specific population.
So what you're saying is that all of this information is individually identifiable?
That's right. to the organizations for whom the care is responsible for being provisioned. So we would never show the identity of a person, an individual, if that group or organization wasn't the covered entity for that individual. But in the case of working with a health plan or with a provider or with a body like yourself, we would be able to show that individual patient identity.
Okay,
Let me share then a view into our software and a couple
I'm looking for
analyses.
other questions. I'm sorry, Chuck, just quickly around the table for the committee, other questions briefly.
So I'm just curious, I'm curious who you have, I don't need names, but the types of customers you have today using this.
Sure. So we have over 60 customers across payers, providers, and life sciences companies. The majority of our business comes from health plans. A few examples might be Cigna, Humana, Centene, Blue Cross Michigan are all some of our customers. We offer a suite of products. The product that I'm showing today is just one of those, but also products around looking at provider performance and network design and utilization metrics as well. The populations, the patient level detail being a main component of all of those.
Thank you.
Other questions?
Maybe at a later time, coming back to the question of identifying all this information by individual and what are the protections built in for that, because that seems critical. But that's, I don't want to go there now.
Yeah, we can talk about that, and I'm sure Chuck can talk about it. He mentioned a couple of certifications that he has. I clarify, and I have some pretty big depth on myself on the protocols for securing health information that I could talk offline about. Yep.
Yep, absolutely. We're happy to, after this call, go into as much detail as we needed on that. It's something that we at Clarify take very importantly, so happy to do that. So taking a look at my screen, what I'm showing is a few analysis that we built on the state of Vermont. What I hope you take away from this is more the art of the possible in terms of the types of questions that we can ask and the problems that we can solve.
Can you hang on a sec?
We need that screen bigger.
Charlene, can you change it so that we can see the screen instead of the.
Sorry, Chuck, we don't want to see you right now.
Okay, I understand.
No.
Want to see your data.
It was working before.
No. All right, that's fine.
All good now?
Not yet.
Is it something on your end, maybe a screen share?
Yeah, we're trying to get
I don't
the,
think so. I think it's on his.
I don't think it's on his end.
It's showing up on mine.
Oh, it's showing up big on yours?
Yeah. I have only his screen on mine, so I think.
Can
we
we
have
just
to-
like drag it? Is this a touchscreen TV?
I don't know.
I don't know.
I'm not touching it.
It's probably the view, because on our screens remotely, we only see the handout. So if
Oh,
it's,
it's just
it might be on the view, if you adjust the view from Charlene's or from whoever's hosting.
Like gallery, go to something.
Yeah. The other thing, maybe unshare the screen and then reshare it.
I wonder if Chuck turns off his video, it might take him off the screen.
Now reshare. That work?
Well, we're down to 2 squares instead of 3.
Yeah, it still shows us.
Yeah, so go to the view, should be a view. Like and like
Would
you can
that
look at, there's different views you can do. You can do
That would be
side
on
by
screen, right?
No.
Yeah.
The state house is pinned, if that perhaps is the reason why. Perhaps if you remove that pin.
You've got it. I mean, Charlie has it. I don't see But he's sharing his screen, so it doesn't matter what you do on your screen.
It's on your end, not on ours.
Yeah.
Because when we see, I can see the handout and I can see everybody in small boxes above it.
Yeah.
So it's on your end, either on the D10 screen or maybe on Charlene's screen. where you go up to the hit like tap the screen. There should be a view, like a thing for view options on the top right.
He's a speaker view.
View. Do you tap on here?
Yeah, go ahead.
Try
Yeah.
tap it on the screen, and there should be some.
It is a
Thumbnail.
screen.
Thumbnail?
I just think
There you go. There we go.
Thank you.
Awesome. See, that's what you need. It was a touch screen.
It is a touchscreen TV.
I thought I was gonna go up there. And be like-
Right, exactly. All right, sorry, Chuck.
No problem. This happens all the time, and we joke that we're a technology company and we still can't figure it out. So glad we're all on the same page. So I built a set of analyses today that hopefully show you what the art of the possible would look like if we were to be able to earn the right to work with yourselves and the rest of the Vermont legislature here. And I'll walk through these screens, and then at the end, I want to show a patient list and how we can get down to that individual level of detail. And I'll hopefully spend about 10 minutes on this to leave time for any questions. The first 3 tiles across the top here are looking at a few different analyses across Vermont. The first on the far left shows me how much utilization, how much healthcare resources on a dollar perspective were used per member per year in 2019. So that's the actual value. The next screen shows in that same geography how much utilization was expected to occur per patient per year, given the unique clinical and social needs of that population. That difference then between that observed and the expected shows us where across the state excess utilization is happening and where care may be poorly managed for the patients that live in those geographies. So from the most macro perspective, I can understand across all of these different zip codes in the state represented here on the spectrum of green, how well is care being managed for those patients. All of my subsequent screens are now only going to focus on those counties where we have identified that there's opportunity for patients to get better healthcare. So now looking within those counties, I want to understand how is utilization trending over time. And I can do this across a number of different metrics, whether we're looking at inpatient, so the hospital costs, outpatient costs, or professional services costs, as well as just the total cost for all of these patients. What I'm highlighting here is the ability to create different cohorts. So if you wanted to look at this for a specific subset of population, you would be able to track and trend the performance of that group over time, hopefully realizing the ROI that this program is designed to achieve by seeing, rather than these costs going up over time, but seeing these costs going down based on the interventions that we're putting in place. Further within each one of these geographies, we can understand what are the highest prevalent disease states or chronic conditions. In this case, we see that hypertension is the largest chronic condition in terms of volume across the state or within these counties. And then also, what are the conditions that are the most costly by individual costs, looking at individual patients that live in these zip codes. Within then each of these different zip codes, these are those high opportunity zip codes that we looked at, we can further see which different health systems are doing a good job or a poor job of managing for the patients that are attributed to them within their geographies. And if we look at here, the red and the green represents those provider groups that are doing a good job of managing their patient population because their costs are below their expected cost at the individual patient level. And then we see a few groups like Dartmouth-Hitchcock who are actually spending far above their expected cost for their set of attributed patients. And then we have other conditions here that allow us to look at, well, they have a sicker patient population, their patients are not seeing the doctor very often, there's more ER utilization, and there's more inpatient utilization as well. So as we think about the types of care managements we may want to identify and program, it could be around ER diversion or reducing readmission rates for every one of these systems. Doing a double click further then and bringing in some of those social and behavioral determinant factors, we can take that same analysis by zip code and actually look at income and see for each of the patient groups that are attributed to one of these income bands, how well is their care being managed? A few things that jump out to me here is that the lower income bands have worse health outcomes across each one of these zip codes. They're costing far more than we would expect them to based on that unique expected value that's taking into account the fact that they're already low income. And then surprisingly, you see for the lowest income band, they're actually below utilization. And that's actually not surprising. Many of these people probably don't have the access or resources they need to go get the preventative care or make time in their day to find childcare, get access to transportation, and actually go to a doctor's appointment, which in the short term may result in lower costs, but over time, as those preventative care is omitted, those costs will actually go up over time because more severe downstream impacts could happen from that.
Can I make sure I understand the first pull out, the chart above this last one, because it was about utilization and whatever the code was, UVM was like in the 50 range and Dartmouth Hitchcock was in the 500 range. And I don't know if you're gonna be able to find the same code, but it just looked really off to me.
Right.
Forgive me, what about it looked off?
That whatever service it was, whatever code it was under, UVM was very low and Dartmouth Hitchcock was very high. And I'm just wondering, I'm trying to understand the total volume better. Is it?
So this, so there's a few things. This data is not representative of all Vermonters. This is
Okay.
Medicare data, correct, Chuck? So it's
Correct.
Medicare data.
Okay.
And the 05403, those are zip codes. And
those
so,
are, okay. I
and
thought
those are only zip codes that were identified in the maps as zip codes where there was overutilization.
okay.
And so when you start to drill in like that, this isn't representing that like Dartmouth is doing worse overall than UVM.
Okay.
This is representing for the cohort of Medicare folks in that zip code, what you would expect using the methodology that Clarify has. We're getting something different than that.
Got it. The big piece for me is that's not like a code of a procedure.
That's right,
the
it's
zip
not a
code. I
CPT.
missed that part.
Yeah.
Okay. I'm really working hard to see this.
Here, it's like,
Yes. Is there a way we can get these slides to post?
This is a live demo.
Yeah.
This is a live demo. I don't know, Chuck, if you could produce a few slides, shots of this that the committee
Or like
can
zoom
see
in or something.
afterwards.
Yeah, I absolutely can. We've actually designed the software to do that for you. I can click a button that pulls this all into slides, but I'll send that after this meeting,
Terrific, thank you.
of course. So keeping an eye on time and keep moving. The other thing that we can do is let's look at the few breakdowns of different social determinants criteria. So the above grid looked at income. In this sense, we're looking at different age breakdowns. So again, in those high opportunity zip codes, how well are patients being managed by different age groups? And the confidence intervals here shrink, the green and the blue whiskers on each one of these blue diamonds, as there's more volume, as those confidence intervals increase and decrease. And what we see quickly here is that the 65 through 74 age range are falling far outside their expected value. So there is more acute inpatient admissions happening within this population, and we can see how it differs and varies by each one of these different age groups. And there's excess utilization in all of these age groups as we look at these acute IP admissions. So what this tells me is if we had better care management programs around specific chronic conditions, like orthopedics or like cardiology, that a lot of this could be prevented by reducing those inpatient admissions to an acute care setting, which end up being very costly and can be managed in an outpatient setting much more effectively with different care management programs. Looking at the next view, so now focusing on only those patients that fall into that 30,000 to 49% income group, they have the highest opportunity to reduce their care coordination, reduce their costs after specific types of surgeries. So in this case, now we're looking at a readmission rate for orthopedic surgeries, and everyone in the higher income bands falls into largely being in line with their expected value. But in the $38,000 to $49,000 range, there's far more readmission rates occurring for orthopedic procedures than we would expect. And in this case, there's different types of care management programs that could be put in place for post-discharge planning, especially around orthopedic surgery for those that live alone or don't have a caregiver that may be responsible for the fact that these patients don't have the post-discharge care they need to really focus on creating the benefit they need to not be readmitted into the hospital. The last thing is taking now a look at breaking this down by race. And again, here looking at ER utilization. So versus an expected value, do we see a difference between race and ethnicity as we break down ER utilization? And what jumps out on the page is that the white population is actually using the ER department far more than we would expect them to, as well as is the Hispanic and Latino population. So if we double click into that one more time, let's look at that white population because they are so far outside that expected value. What we see is that that's actually largely concentrated in the 3 lowest income bands. The higher income bands are using the ER as appropriately as we would expect them to within one confidence interval. But it's these 3 lower income bands where there's a lot of excess utilization of the ER that's happening. And that could be for a number of reasons that we can help diagnose further. But I can certainly say from my experience working in Medicaid plans in Chicago, if your heat goes out and the ER is a place that you can spend a day because there's TV and there's toys and there's warm air, there's other reasons that could be adding to the fact of why someone might be going to the ER, driven by these socioeconomic factors rather than clinical factors. So the last view here then brings back those maps and allows us to see if we look at where these low income members are that are more frequently using the ER, we can break that down by where the white population lives versus the non-white population and see the difference in utilization that's occurring by geography as well. So as we think about the areas where we want to focus care management, or perhaps the health systems that should be responsible for caring for patients in these geographies, you can better map those to specific areas where those patients actually live and deploy your care management resources more effectively towards these patients.
Can I ask a question?
Go ahead.
Are you able to see information related to limited English proficiency?
That's a great question, and I don't know the answer to, and I will follow up on. I don't have all 400 of the social determinant factors memorized, but I do presume that there is one that maps to that, and I can certainly find out for you. So the last thing I want to show here, so after taking all this information, just going back to the top, we saw that there was a high prevalence of hypertension in this population. And one of the examples we saw that Dartmouth-Hitchcock was not doing a very good job of managing these patients that are in those higher utilization counties. And so just to show what a patient list might look like, this is another part of our software that looks at the overall state of Vermont focused on Dartmouth-Hitchcock Health Plan and looks at all of the chronic conditions within the attributed set of patients to Dartmouth-Hitchcock. And one of those is that hypertension bucket that we saw. And in this case, there's a 57% prevalence within this population and $18 million of standardized opportunity that says if these patients were managed back to that expected value as we would expect, that's how much savings could be attributed to the specific health plan and to the state overall. And then viewing the details, we can pull this up by physician group. And I just want to click through and show how you can use this cohorting capability, whether it be patients with hypertension at Dartmouth, or it be females that are white who live alone in zip code 12345 that don't have access to transportation and have highly unstable housing, how you could generate a list of patients that meet that exact criteria to then focus those appropriate interventions on to be very targeted with the type of precise interventions that you want to make and actually inform what is the right and most appropriate intervention for a patient with that certain set of criteria. Whether it be Uber vouchers for someone who doesn't have transportation or Meals on Wheels for somebody that has diabetes, you can begin to more precisely identify the actual needs of each one of these members across all the different categories for whom we had the social and behavioral determinants of health information for. Now, because this is on our Medicare data, much of this is blank, and when it's on actual customer data, we pull in all of the social determinant factors. But in this case, you can begin to get a sense of some of the ways that we fill in this data and then how this can be used to further slice and dice the data and create those precise cohorts. So let me pause here and see if there's any questions or Josh and team, if there's anything that you'd like to add on.
Thanks a lot.
I mean, back to Representative Lippert's question, it does get it looks really granular and it gets a little bit concerning with our small population of people of color. I mean, like, this is just a lot of information about people, and the more you break it down, the more you could be talking about. I mean, I'm impressed, but I'm a little scared, you know. I don't know. This is a great power to have all of this information, and I don't know. I'm trying to understand its highest and best use, you know, as opposed to ways that it can frighten people.
Yeah, so let me first say that I work with a couple of different health information exchanges in this country, and you may know, some of you may know, I also worked for Molina Healthcare for a number of years. And in the private sector, they have this data on us, on all of us, and they're using it every day for everything. No, so, but I
And we authorized it in the fine print of something that we signed without reading it.
I understand where you're going. So, but what I just wanted to say is that this is very present, this information. The health information exchanges that I work with and Molina, when I worked for Molina Healthcare, we are, all those organizations and the state operate within HIPAA, and have to assure that the data is not exposed, and I don't know how many gazillions of dollars of liability insurance Clarify carries, but I know that my health information exchange clients carry gazillions of dollars of liability there. And most of us are hosting in the AWS cloud, which is extremely secure, and in a secure instance of that cloud. So we could get into a lot of detail about how that happens. In addition, Chuck mentioned high trust. That's gold standard for security. And so what we can do, we can't assuage fears that big government might do something that we shouldn't with it, except through transparency. But we can assuage fears around it being insecure. And we could, you could, put the bounds around what it could be used for, the information that would be brought in. But I don't know that it's actually necessary, because you already have all of the claims data, and you already have all of the, you have these data, you have this data already today, with resident within state computers, and within state departments. With the exception of data that's gathered from public sources externally on social determinants of health, which is for purchase on the market. And so I recognize the concern, like we're seeing real stuff here, right? You know, so I understand that concern here, and I think it's certainly worth having a broader discussion about, or a longer discussion about. So I would just, you know, I just give you some context from my perspective on it.
But, you know, thank you for that. I will say that the reason I asked the question originally about where the data comes from and how is it personally identifiable was because it does open up individual healthcare files to scrutiny by insurance companies, and that it could be used. It could be used nefariously. That's a concern I think that anyone would have. The issue is, can it be restricted to population-based analysis rather than you do have to get all the data about individuals, but it can be without identity. So you could look at population issues within specific geographic regions of the state, for example, without identifying.
Yeah, much like V-cures, you could de-identify it all coming in.
Yes.
So you don't know who it is. And you could, and like our other reporting metrics, you could not report any cells smaller than 10. So 10 or bigger. So you the issues there. And I think that's the V-cure standard is 10 to take it out and not report it as a cell. And so, you know, those types of rules can manage a set at the state level. You can also, I think that there's contractual language that can be utilized with a vendor. So if you have a vendor doing specific tasks, the data responsibility resides with the vendor in that instance, as opposed to in the case of VCures where the state is managing that. So just there's an organization called Fairpoint that has every single commercial medical claim for every single human in the United States. It's created under a special congressional law years ago, and it's an organization that was designed to have that information in fact. And so, that I'm not assuaging your concerns again by bringing up
This wouldn't be the first time.
Can I just say one thing? So, data is very scary and down to the personal identifiable, especially with medical. But to me, I look at having data as a huge opportunity. And just another real world example is when we started, when the US started collecting data in the 70s to help create credit reports, it brought down the interest people were paying for mortgages from 20 to what we see today. And that same data is now being started in other countries to do the same thing. So you just look like a comparable market of where costs were outrageously high and data has really helped. So I would just hope that we would keep our minds open to what data could do, because it is pretty powerful. Coming from a company.
I was just gonna say, you
I was
work
gonna say,
with data by any chance?
I work for a data company, so I'm all about data.
No, I think we all agree with you.
Yeah.
The concerns
Yeah.
are real concerns, and they would come up going forward.
Yep.
So I don't want to get us off track, but also this reminds me of some of what's happening currently with the ACO.
Right. Exactly.
With OneCare, which is specific patient feedback to medical practices about ways to improve patient care. I mean, I
was gonna say,
this is what that's all about.
right, the concerns that are being raised around this table are real concerns. But this is happening right
Right.
now. And that's how the ACO's model, and that's how the multi-payer model works, is individual beneficiary attribution to manage care within the confines of some strict requirements about how that information be shared. But it's a matter of how else can that data be leveraged to do things like we're talking about here from a public policy perspective, not just a care plan.
And the addition of the data of social determinants.
Right.
I mean, that's pretty big.
It's very powerful. It's very powerful, and the confirmation.
I mean, ACO has data,
Oh, yeah.
but they don't have the social determinants.
Social,
power.
right,
Okay.
well,
Like this.
but
They
the
can buy it.
FQHCs
They can buy it.
do.
Yeah, I
They
mean,
have a broad
right.
analysis of that.
I mean,
Some pieces of that.
Yeah, and imagine being able to use this on the front end for an initiative that someone wants to do, right? And to see to answer the who and what,
Right.
like who would this be valuable for? And we run into a number of issues right now where we're like, maybe these folks, maybe those folks, we can draw a band around it. We can actually, if we went this way, we could actually be very precise about who it would be valuable for. And we can make it more fuzzy if we want to, if we want to change the focus a little so it's not quite as precise, we can. But I guess what I'm saying is to imagine it being very precise and then purposefully making it fuzzy as opposed to the other way around, right? I'm demonstrating how old I am by making it fuzzy.
All right, so what else do we need to know at this point? I understand that whenever I hear something like this, I think back to the work that was done in New Hampshire on identifying overutilization. Yeah, so this is the next step in the world of technology.
Right, and that to tie it back to a tool that you use, if you use something like this, you could see that you had overutilization in a particular area, and then you could focus of learning community for your providers and your consumers about what they, sort of what the best practices in terms of treatment, so that because sometimes the overutilization is really driven by consumers saying, well, I need that, and the doctor's not saying no. And so it gives you another sort of way to identify what the tools are to bring your costs down and make the healthcare sort of more affordable. So
Is there an example of using this to analyze prescribing practices and overprescription of specific types of drugs?
Yeah, I'd see if that was a question for me or Josh, but today that is something that we're working on. Prescriptions can be tricky, if you will, especially as you think about things like opioids and who the responsible provider is for actually administering those. It often varies if it's the PCP or an operating surgeon or someone that was actually further upstream for doing that. So over time, we do have the prescription data as well, and that's an area where we're looking to build out our analytics further on.
Thank you.
I would just say that I have a question. Again, I don't know that it makes sense to get into it now, but as you're setting the standard by which overutilization or et cetera, somehow I missed how the standard got set that against which all this is measured, because that's critically important. Because whatever the analytics that go into setting, this is what we would have expected and would have been not just expected but considered appropriate. So that's a key piece. And again, I'm not suggesting that we go into that right now, but that's a key piece, because unless there's common agreement about where and how that is determined, everything else follows from that and either rises or falls on that.
Yeah, absolutely. And I can follow up with more detail about this afterwards and how Clarify creates that expected value. It's something that's very unique and a huge differentiator for us. Most companies just say, let's take an average of readmission rates across a certain population, which doesn't take into account the fact that patients are different. And so the case mix adjustment that we do that actually creates that expected value happens at the individual patient level. And so if you look across our entire national data set of all patients that we have in our data and say, for patients that look like this with the same clinical needs and same social determinants of needs, how much utilization usually occurs within that set of patients? And then when you apply the actual individual member that you're looking at, you can compare it to that expected value at an individual patient level. So that's a very sort of like high level summary of that, but I can certainly follow up with more details if you'd like to dive in further.
I just have one quick question. So I asked before who your customers were, and I forget if you said, are there any states using this today, or is it just all medical plans?
Medical plans, health systems, and some life sciences companies as well. No other states like yourself that I can think of off the top of my head.
Thank you.
So we did a special break because we'd be the first.
First one, exactly.
In fact, you might like to pay us to let us allow you to work with us.
That was what Senator Westman was gonna.
We'd be willing.
I'll take that back to my board and see what we can do. No promises.
I think I'm trying to understand if you could look at a medical center and see if they were turning away older women for heart procedures, or they were underserving the Black population in their community, or they had a high maternal, mortality rate. Or are you saying that you can also show us a lot of that with granular detail for different medical centers in our state and hold them accountable to disparities?
Yes, exactly.
Okay.
You could see it for the patients attributed to one of those medical centers is a certain set of population having better outcomes than another set of population. Now, you then probably want to drill into that a bit further and understand what might be the drivers of that. Is it individual physicians that could be practicing care different than other physicians in that practice? Or is it perhaps that set cohort of patients don't have the resources they need to get to appointments at that center, even though they're responsible for their care? So So it's definitely multifactorial, but yes, we can show all of that.
Which, if I may,
Regression analysis.
leads me also to the question I had earlier was, how are patients attributed to particular medical institutions? Because I'm thinking of attributed lives, which that's not what this is. But again, if someone's attributed to one medical institution, but they actually use multiple institutions, that may not fairly.
Yeah, so you can look at it in two ways. You could look at the hospital and say, what are all of the procedures that this hospital performs throughout the year across all the patients that they see? But the question of attribution is actually something different, something very technically defined by CMS as you look at ACO programs, where there can only be one attributed provider for a patient based on a specific set of rules that has a look back period based on all the utilization that that patient had in the prior year, and says, based on who the PCP they saw the most often for a specific set of procedures, who should that attributed provider be that's responsible for the entirety of the care for that patient? It doesn't prevent us from looking at where is other care being provisioned by other providers that might see that patient. So it sort of depends on the lens that you're looking at performance on.
So it is in fact the same as the attributed lives formula for the ACO.
Yes, our attribution logic uses the CMS MSSP ACO methodology.
I was assuming you were using language that was similar, but it might be different somehow.
Except Representative Lippert, yes and no. Yes, if that's what you're trying to do with it. No, if what you're trying to do is something else. So if you're trying to attribute it for primary care medical home reasons from a state perspective, right? Forget about ACO for a minute. You could use the ACO methodology to do that attribution, and then you'd have apples to lemons comparison, at least to the ACO. If you wanted to compare Dartmouth to UVM, you wouldn't want to, you'd want whether Josh Slen, if I went to both, I'm not sure that you'd want to attribute me to one, right? You'd want to know if I got my hip done at one and had a heart attack care at another, you might want to know how they do heart attack to heart attack and not care that it was Josh in one and hips, you know what I mean? You might want to do the.
And I realize we're getting deeper into the, what's possible and what's not possible, but so.
Yeah, I think it's great. We are, I want to do a time check because we're quite past our time.
I was going to
I
say the
agree.
same thing. I wanted to say thank you to Chuck for being with us and bringing this information to us. And as we go forward, it may be that we need to learn more and to dive into greater detail. So thank you.
That's a dimension.
Wonderful. Thank you all for the opportunity to speak with you. It was a real honor and a pleasure, and I hope we can continue the conversation.
Yeah, thanks, Chuck.
Thank you. All yours, Joshua.
Well, we are up on the public option, so Tim,
So
all yours.
I now have a corollary to you never want to do the presentation just before lunch because everybody wants to leave for lunch. You never want to do the presentation just after whiz bang data.
Not a slick, huh?
So I'm cognizant, center lines, is kind of how you set us up, right? To think about this morning, what is this that we're talking about? Who's being helped? And what kind of timing are we talking about? Like, what is the time to something on the ground? So in this conversation, we'll talk about the details, just to kind of bury the lead a little bit. We're talking about the small and individual group market. 70,000 people maybe, if there's enough interest. Unclear about how much we can help, and we'll talk a little bit about what the attributes there are. But to kind of like just get to the bad part, it's not immediate, right? You're gonna need to do, our recommendation is you're gonna need to do some more thinking on this. And that thinking will lead to then plan design and implementation. So we're 18 months away anyway from getting there. But I think it's a conversation worth having, and I think there's some real opportunities here for Vermont. So public option, right? We talked about it a little bit before. What we're really talking about is the state in some way, shape, or form leveraging their power as a state entity to create a new option, in this case on the exchange, for consumers to purchase, right? You can do it through a state-run system, you can do it through a public-private partnership, through competitive bidding, you can have somebody buy in to a Medicaid plan. But at the end of the day, it's the state creating an insurance option for folks to get into. I'm on slide 29. When we talk about who can we help, right? We're talking about the Vermonters who are in the small individual group market, about 50-50 split of 69,000 between small and individual market. And the folks who are uninsured, right? To the extent this would create an option for them to get insurance. If you look at what other states have done, right? So if you think about Nevada and Colorado, which just implemented a public option with some, like, what I would call pretty aggressive rate limitations in terms of what they expected premiums to do year over year, you could get some savings theoretically, right? You could, based on the silver plans from last year, you could save $1,300 a family if you wanted to put like a real rate decline into statute to sort of say this is what the public option has to achieve. Of course, you know, insurers are going to be happy at getting market share. They may not be happy depending upon how it is we structure this or how it ends up getting structured. And providers, as we'll talk about, if they're going to bear the brunt of that 5% premium reduction, or whatever the premium reduction ends up being, are going to be unhappy because it's going to come out in terms of rates. So on to slide 30, before we get into kind of just the implementation design levers and kind of what you need to pull and how you need to do this, clearly to make it people into the system and to make it viable on the market, you got to get savings. And if you're going to get savings in some way, shape, or form, you're going to have to spend a little money. There's going to have to be some financing there. So I said you can sort of drive through on provider rate reductions. You can just create a public option and say you're going to pay providers at, I don't know, 150% of Medicaid or 160% of Medicare limit rates. You can hope and build the public option in such a way that competition could drive premiums down. A little more theoretical, a little more actuarially based, a little more uncertain as to whether or not straight up competition on plan design and networks will drive competition. You can put in state dollars, right? You can leave the rates the way they are and just subsidize premiums. And these are all kind of additive. You can apply for federal dollars. And we'll talk a little bit more about this. To the extent you can get premiums below the benchmark in the marketplace, so that premium tax credits financed by the federal government are less than they otherwise would have been, you can recapture some of those savings from the federal government to come back to the state to help them either offset this or other priorities that the state may have. So let's talk a little bit about considerations here. If you want to think about doing some work and some more detailed analysis around, is this going to work for the state of Vermont? You have to think about what type, right? As we talked about, there's a public-private partnership where you're leveraging you're leveraging private sector plans in the state to deliver care. You're just setting the rules and the plans are delivering the care. You can do a buy-in either into Medicaid or the state employees program or a state-run plan. The state-run plan, you know, candor, given the conversations in Vermont over time, probably doesn't feel like a viable option. Washington and Nevada, the two states that are live, have chosen to use a public-private partnership. You may want to think about a buy-in. Does it make sense to sort of offer Medicaid, or at least consider thinking about having folks buy into Medicaid or to the state employees program? Has not been viable in other states, but given the market here and what you're thinking about in Vermont, that might be something you want to consider. And then once you decide kind of, you know, what structure you want to use, you have to think about plan benefit design. And here, obviously, you've got to meet the standards for QHP. We're going to be offering, if it's going to be offered on the exchange, if you're going to want to get premium tax credits associated with the enrollment in the public option, it's got to meet those basic levels. But then you can do some other things that are kind of unique, right? You can use plan benefit design to achieve other policy goals, right? So Colorado, as they're thinking about what they're going to do, is put in goals around network adequacy and disparity, and are networks being built in such a way to reduce equities in the system, right? Are there other benefits that you want to put in, either enhanced cost sharing or reducing deductibles that reduce disparities? You can use the design of the benefit to get to some of the issues that we talked about just before lunch in terms of disparities and health equity. as well as sort of if you think about what's going on with the ACO here in Vermont, do you want to use the public option to continue to drive value-based payment and system change in the way that you're structuring networks or payment arrangements among providers to sort of derive benefit back to the state. How are you going to finance the premium savings? So we talked a little bit about the levers that are there, right? You can drive rates down. You can get a 1332 waiver out of the federal government. All those things I think you need. I know you need a little more robust and sort of rigorous actuarial analysis that we can provide here. I think it's going to be clear. You're going to need to really understand uptake assumptions on how you set up the public option relative to what the premium is and what that and how that's all going to play out and what that bottom line ends up being in terms of ultimate enrollment, so you know what the ultimate savings might be. Other things to be thinking about are the impact of ARPA premiums if we have a second round of Build Back Better and the premium subsidies that are now in place continue to be in place. We need to think about the impact of small employer premium reductions, right? So a lot of interest in sort of, can the public option help the small employer market? And it absolutely can. In other states, public option is available in both the individual and the small group market. Need to be a little careful, right, about how you describe that and how we sort of go about thinking about the small group market, because the way federal savings are calculated is you get pass-through savings to the extent federal subsidies are less than they otherwise would have been. So straight up, if the premiums are down and they're spending less on subsidies, you're going to get some of that money back. But if you design this in such a way that small employers really begin to aggressively drop coverage and put people onto the marketplace, which would be great for small employers, you're actually going to drive up the amount of the premium tax credits because more people are going to come into the marketplace than otherwise would have been there. And so that actuarial kind of what happens to the market when you do this is going to be important. And what problem are you trying to solve? You could solve the small employer problem, but you might lose your source of federal savings. And then to the point we had this morning when we talked about cost growth, this is a real opportunity here, right? To the extent you're going to think about cost growth targets, you want to think about premium reductions or growth targets for the public option that are kind of in conformity and kind of match up to that. You guys are killing me here. I'm not going to lie. I'm out of breath. I thought you'd jump right in. Questions.
Oh, let's take a break here and see if there are questions.
Yeah.
Yeah, good.
Well, one of my questions early on is when we talk about who does this benefit? And
Yeah.
one of the things that we talked about is those for uninsured Vermonters. And I want to posit that I think that's a very, very small group in
Yeah.
Vermont.
3.9%.
We have the second lowest or sometimes the lowest uninsured percentage in the country. California, I mean, I think we forget, but California still has like 12% uninsured or something, a lot of the latest data I looked at. So this is not, and just the churn in the market, those people who are never going to be insured because they don't want to be insured, and we know there are some of those. So I think this is not a solution this is not a solution that should be pursuing, quote, the uninsured in Vermont, because I'm not sure that, even though there's a percentage, I think we have a lot of underinsured, but we don't have a lot of uninsured Vermonters. And so I guess help me understand that if you take that, just say, well, this isn't going to solve that because it's not something that needs to be solved. And
I think the analysis stays the same in my regard, right? It's
I
really
just
kind of
wanted
a
to kinda
universe.
help.
Like, here are all the people that could be helped. I agree. I tend to agree. It's not, given the dynamics in Vermont, a public option isn't what's going to scoop up those last 3.5% of people. I think all the things you just described. People are going to choose to be uninsured, whether there's an option for them or not.
there's some kind of churn process that just there's going to be some churn.
Right. I really think it's as much an option and something that's going to drive change for folks who are either currently insured, underinsured, or in the small group market, and they're going to see this as a cheaper, sort of more beneficial option to them to get insurance because they're already getting it.
When you talked about what type of public option program buy-in either via Medicaid or the state employee program. I think I heard you say that is not viable in other states.
Other states have chosen not to do it.
And do you know why?
I think it's the pool, the risk pool and the market that's there for the public employees and Medicaid is very different. And I think they couldn't get insurers who were going to be willing to pay to play if it was going to be an insurance-based system. And then, you know, the government, all the things you think about in terms of making a government-run program that much bigger. I think the politics and the market pieces came together to say it's just easier to contract it out, if you will, to use the existing market to deliver the service.
So it is an interesting thing to think about the public employees retirement system as an option for a buy-in program in Vermont versus a commercially run
Retirement program.
healthcare program, sorry.
That's where you said-
Sorry, I started with public
Yeah.
employees and then I put retirement instead of healthcare, so yes, thank you. But just to think about that in comparison to the program, if it was the small group as it stands today, and you know, a new plan in that standalone plan, if you will, in that market that employers could buy into or individuals could buy into, however it was designed, they would be different from an actuarial perspective. And I don't know, sitting here, I don't think any of us here know, sitting here today, which would be better and what the puts and calls on that conversation would be, right? So I don't know if there's a political conversation around this, as there always is, around using a public system as opposed to doing it on the private side. But that conversation, I think, might be informed by and might be pushed in one direction or another by the information on what it would mean for small employers.
We have divided the small
Right.
small employers, small group and individual markets.
Combined, uncombined.
Uncombined.
Like, uncombined, to take advantage.
Yeah.
Just
Yeah.
briefly, take advantage of it. Yeah.
So one of the,
Does this assume they're still combined?
This, well, I mean,
I mean, when I was reading this, it made it sound
honestly,
like
I'm not gonna lie, like I missed that you uncombined them for the purpose of the ARPA subsidy. I thought they
Yeah.
were still combined.
No,
So
I
this-
mean, when I was reading through this,
Yep.
I'm going, no, this is not actually the case.
Right,
We're-
and that's-
we're
And it's not a permanent.
Right.
situation.
But
they're uncombined pending ARPA. So the question would be, and that's another question for the design or conversation would be, and this is a conversation that we've had, that I've had with Nina directly, right, about which is, well, this, how much more valuable is this, or more critically important does this become if the ARPA subsidies go away, right? There's a bigger pool then, there's a problem because people will lose subsidies that they have today, or even not go away, just be reduced, right? And the latter is more likely. You could tee this up to plan for that eventuality. And it becomes more urgent perhaps, given that is an eventuality. So that's another way to think about it.
Right, so we talked about the market, right, and I think we gotta catch up with where we are. The other considerations here, and we talked a little bit about this morning in terms of the cost growth. Like you've got multiple agencies who are gonna kind of have fingers here, and you need to think about what is the right locus of responsibility, whether it's the Green Mountain Health Board or it's the insurance commissioner or the access. And then the last two issues here, just in terms of if you wanted to do a study, like who's gonna do it? Right, that's the same sort of question in terms of administration. Some states have had the legislature do it. Some states have said, tell the administration to do it and have them come back and sort of do some more analysis. I think it's 6 of one and half dozen of another in many respects. And then, as I said at the beginning, timing here. Under any circumstances, if you're going to use a market-based approach or you're going to use plans, you need to plans time to build it. That's usually, a year you need to give them advance. And so we're probably talking about 12 to 18 months before you could say, beginning of 2025, 2024, this is when we're going to start offering a product like this for folks in Vermont.
I think the one thing is, that Tim didn't talk about that I know from Colorado is that they have done a ton of stakeholder work in
Yes.
terms of, from a consumer perspective, sort of what they want to see in the product. And with their providers and payers to sort of get to what their model is. And so that would have to be part of whatever sort of the next step is, a fair amount of stakeholder reach out.
Lori had a question.
Go ahead. So I guess I have two concerns. One is concern around the conversation about the rates.
Mhm.
We're hearing loud and clear that our rates are too low, and to put any downward pressure on that, I think we can't do. At least I would not be supportive of that. My other thing, and I don't hope anyone takes this the wrong way, because $1,300 is a lot of money, but I would have thought there'd be more savings to the consumer. So can you help explain to me what?
Well, if you think about what the average premium is, $2,100 a month, the silver premium, that's,
Oh, I'm sorry. I'm thinking my mind's in the high deductible plan.
this is
So
on
this
premium.
just
It's not like anything else, not cost sharing, it's not any of the other things. It's on
Okay.
premium.
Thank you. That's helpful.
Can you say that again? Because I was,
Yeah,
Can you
and so if
say
you
that
think
again?
about, let me just make sure I get the right numbers. If the average silver premium in Vermont for 2020 was $2,100. If you think about reducing that, for example, to the levels that Colorado is thinking about, where it's actually going to be like a 5% reduction in premium year over year. You could, that could translate out for an individual to $1,300. That $2,100 premium would not grow, it would go down. And so that monthly savings would translate to about $1,300 over the course of a year.
And my concern was, I was thinking that's not really that much, but I'm thinking of then the high deductible piece of a lot of plans where, you're paying the premium, but you're not actually able to use anything because,
there's a high deductible.
right. So that's
But that is like, my sort of quick analysis of what it's looking, what you really need to do is actuarially look at the market and kind of who's there and what we would really expect to see as a plan. I'm not gonna lie, as we sit here, I think Colorado is pretty aggressive to say they want to look at actual premium reductions of that amount. That's pretty aggressive. It passed and they're moving forward. Of course, it's years out before they'll see that. impact.
Are they taking it
They
from
have-
provider reimbursement rates? Yeah, that probably would not fly very well in this state.
no.
Right, and Nevada says, it's sort of a mix, right? It's almost a bidding situation where they're using their Medicaid plans and they say, we want you to bid, but oh, by the way, if the bids don't come in where we need to come in, after a certain period of time, we're gonna have a backstop of rate reductions to make sure that the public option is viable.
Any other questions on this one? There's a lot of questions about this one.
Yeah.
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 And,
A lot.
huge. I know when some of us think about a public option, we think about it combining our VSEA, our NEA, and our municipal folks together in one little insurance risk pool, which is a whole other,
Yeah, that's
Right.
not this, right?
yeah. We could do that. But we don't get there's not a lot of enthusiasm. for it. Okay. Any other comments?
Well, I'll just ask this. Who's looking at this? Who are the stakeholders that are,
If you design,
apart from having it be completely state-run, which is not really a viable option, I don't think any of us see.
the number one beneficiaries of this are the small employers.
Yeah.
So if you design a plan that costs them less, they will like it. Right? And their employees will like it if it costs them less. And so this is when you look at who gets helped across all these different options here, this one is targeted directly at that market, which has fewer other options in Vermont today that are helping them.
So, and what is the total count of that? Is that
That's what
like
I
the
was gonna go.
70,000?
There's 35,000 in the small group market today and 30-something thousand in the individual market.
Yeah.
That's about it.
And they're probably the most underinsured.
The small employer, so I don't have the analysis in front of me, but I would say yes, they are more likely to be underinsured than other
High
groups,
deductible.
And probably younger.
mostly younger.
So it's worth keeping it on the table for that reason.
So to be low cost, it would need to have a big infusion of dollars.
$5 comes somewhere.
Yeah.
Right.
So what,
Well, I'm gonna sound a broken record, but if it's all younger than that, these are the people that would use primary care. I'm not gonna squeeze primary care providers to pay for this.
Yeah, exactly.
Just, you know,
Well, it could be done in combination with reinforcing primary care.
Yes.
and
it
then
could,
making that option.
absolutely, but,
Right,
you know.
yeah. Is there anything that we should know about the tax credit process?
Just as I said, it is a couple things. One, no state yet has gotten pass-through funding on something like this. Any pass-through funding that states have gotten have all been on reinsurance programs, which I know you guys talked about and eventually said no to. So the first state that comes in, and Colorado, Nevada, and Washington will, with the waiver request to get pass-through funding, will be the first state. We'll learn a lot from CMS about how they're viewing the actuarial analysis that has to associate itself with that and what it's going to take to get approved. But to my point, they are very bound by the guardrails that they are associated with, which is it's got to cost them less and access in general, and access has to be the same. So you can't make it so fewer people are covered, and you can't cost the federal government less. There's lots of ways to do that, but as I said, to the extent you're creating a market where people may be leading employer coverage or any kind of coverage that's not covered by the federal government into subsidized coverage, that's a good thing for those people, in my view. They're getting better coverage, but it's going to make it more expensive for the federal government. They can't approve it or not approve it, but they can approve or not approve pass-through funding based on that.
so right now, they're not kicking people off Medicaid, right? Like if you have a change in income, there's a stay on. So, I mean, that's an interesting time to study what that is costing each, the federal government per state, right? People have called in to report a change in household income. I just did this. You go through the whole process and, after like 3 hours, they said, nothing's changing for you right now. I just got married. So that's a huge stay of execution in our household, and I just wonder how many people are calling, during this enrollment period who are being given a huge amount of relief right now. How are we capturing that information?
Right. I mean, I know CMS on that part is doing a lot of thinking around this winding down, unwinding, they're calling it, right?
Yeah.
So when they start to sort of release that, when they lift that,
They start doing redetermination.
right,
Right.
it's going to be a huge impact. And I know they're doing a lot of thinking on
Yeah.
how many people are going to be kind of moved around and
Right.
moved off who had this state execution.
Right.
And it's like 10%, like roughly across the
Yes.
country, it's like 10% of the population on Medicaid.
Okay.
Is that what it is?
If you
Wow.
sort of the states I've been working in, they're all right around 10%. So I'm making
Yeah.
a generality.
Yeah.
I don't know that old, but yeah, it's about 10%.
Yeah.
If you just think about how much there generally is churn and
Yeah.
redetermination.
Right.
The other thing is around premium. So the extent that people would have turned off because they didn't pay their premiums, that's not happening either. So it's both sort of changes in income or family
Yeah.
and then sort of other reasons.
Right. I would think this is a really good time to talk about a Medicaid buy-in or some way to step those folks, just start this unwinding
Right.
is going to be just a really blunt impact.
What are the options for those
Yeah.
people as they roll off?
Yeah.
At the least, I would think that we need those temporary navigators again, because you're gonna have 14,000, 15,000 people rolling off. But remember, it'll be 1,000 a month. It won't be all at once, right? It'll almost certainly roll off on the timetable, on a calendar year timetable, not on a cliff timetable. So that's how we do eligibility today. You come in June, you get redetermined in June, not you come in June, you get redetermined in January, right? Like we don't do that today. So
I think there's some decisions for the state to make about how they do that roll off. And so part of it is about how, from a state budget perspective, how long you want to keep people on once any sort of enhanced match goes away.
and having some navigators in place to help them and that process in place to help the individuals that will come off. You know, I know I'm coming off. What do I do? Would be one thing that could be done, right?
No, I see a hand up with Nolan. Go ahead, Nolan.
An accident.
You're- I've got to get his headset on.
My microphone on my computer's messed up, so you guys, I was talking and nobody could hear me. I just wanted to just weigh in to let you know that, like, you know, AHS has already been thinking about this, and my understanding is they've already been, I would say, lobbying the federal government to make it more of a roll off versus a cliff, and try to extend it. So we know that we're going to get this. The MOE is going to be at least through the end of March. Which means we're also going to continue to get the 6.2% FMAP bump. But we're assuming, unless we hear otherwise, that could end then. And then the question becomes, what does that look like? And so there are conversations. For all we know, in next month, we might get more indication that it continues through the end of the fiscal year. So I guess my point is that the AHS has been thinking about this and talking with CMS about it as well. So.
Thank you. I mean, so that'll be important for our committees pretty early in the session.
Yeah, and for the budget.
Yeah, absolutely.
It's the 6.2, because tied to the 6.2% FMAP, and that's about $22 million per quarter. So.
And is it, okay. Yeah, I have a lot of questions, so, but we'll save those.
Save those.
You can call me or ask me offline anytime.
Okay. Thank you, Nolan.
Yeah.
So you said it's Colorado and another state that are.
Nevada, Washington, Colorado.
Nevada, Washington, Colorado.
It's in your white paper.
Washington is actually delivering care. Colorado and Nevada are kind of in the implementation.
Okay. And in the white paper talks about other revenue sources they're using to advance public option.
Yeah, I mean, it's generally rate reductions or premium reductions. There's not a lot of other.
They're not putting
Right, and even
marijuana dollars out of
and even Colorado, where they're at, I think it's Colorado, where they're asking for a 1332 waiver. They're not using the 1332 money for the public option. They're using it to finance another state program.
Okay. Well, I think given the time that we should probably go ahead and move ahead to the blueprint discussion.
And before we get into the blueprint discussion, I just want to let folks know that Julie and Tim are gonna zip right at 3. So if we do run over at all, Tim has a plane to catch that's a little tight. So
Well, and good timing, apparently beginning at 5 o'clock, this Washington County is under a weather advisory for bad stuff.
Oh, they've moved it up.
Really?
Yeah, 5 o'clock. So we'll try and get.
Let's hope it doesn't get here before 5:18.
You'll be. Our airport is terrific.
I gotta believe a little weather watch is not gonna stop somebody flying out of it.
That's a different county. All right.
6 a.m. tomorrow. I hope it doesn't affect that.
So who's going to take us through the blueprint? Terrific.
So,
And before that, I just want to say thank you all.
Sorry, kind of.
Yeah. Thanks a lot. I don't know if we got a chance to say that before you have to scoot out.
And if we have questions that we'd like to follow up with you,
Absolutely.
just work with Joshua to get to you about things I might like to ask.
yeah, we'll be leaving the room, not the country or anything like that.
Okay.
Okay.
So, Blueprint for Health, we're on slide 35. And, to put the lead right up front here, we believe that like the MNG program that we talked about, the Moderate Needs Program, very different programs, community health teams, 168 full-time equivalents around the state being funded with tens of millions of dollars.
Right now, 160.
Yes, it is. I mean, it may be 172 right now, or 130, or 165 or something, but yes, it's the right number as of the data report that I have. So, those are the individuals, and then there's a bunch of other funding. So we're funding the hub and spoke through those community health teams as well, and we're providing supports for Ncqa accreditation at the PCMHs, which amounts to another almost 10 million. This is all just straight out of the budget document, so it's not my made up numbers. It's the governor's numbers. So not this year's, last year's. So I haven't seen this year's yet, obviously. So, but those community health teams have been in place a long time, right? And I do remember when we did the first one, right? First three actually. So when those got phased in, we didn't know if it was going to work or how it was going to work, and we allowed it to be very flexible, and it has been very flexible. And at times there has been more reporting or data available, and right now we're sort of at a low point in that reporting and data available. And it's moved around from the health department to DIVA up to the agency's office, so it's like come find a home. And I'm not saying any of that is bad. There's lots of reasons for doing those types of moves. What I am saying is that we can do better at longitudinally tracking what we do, and at actually demonstrating who we're helping and how we're helping them. And we need to do that. And we need to do that because if you want to fund a public option or do a cost growth target, you need to have programs like the Blueprint that you can book savings against. Not that you just, if you're Blue Cross Blue Shield today, it's a check you write. You don't have anything on the other side to bring back to your board to say, I wrote a check for 3 million and we saved 5. We're not doing ourselves justice by not producing that feedback loop, right? If we have a great program, we ought to get credit for that great program. And credit would mean lower growth rates to help meet our growth rate target as a state. It is a statewide population health program that can help us meet a cost growth target, except it's not being measured that way right now. So, I think that is a really big point here. The other point is that I do believe, I'm a Blueprint believer. I believe that is the best way to deliver care, which is locally, and to support primary care medical homes in delivering their care with teams that are need blind, that are available regardless of what insurance card you have or what zip code you live in. If you have a primary care medical home, and virtually all of them participate in the Blueprint, virtually all of our primary care providers do, they ought to be able to refer to supports. And in rural Vermont, it's especially important. I think that helping to move that forward is something that would be very powerful. So I think I've covered everything on 35. I mean, these are the conclusions, right? I didn't bury the lead, right? Like they're right there. So on slide 36, I've a little bit of the numbers that I talked about. So staff capacity paid for by the payers, quality medical payments, Ncqa recognition, and then that Medicaid assisted treatment to support our hub and spoke. Again, hub and spoke, widely acclaimed and built off of our existing community health teams. So I want to point out here, though, that we are still spending about $10 million here to support payments to the patient-centered medical home practices for their Ncqa recognition. And then
I'm sorry, what is NCQA?
the National,
Committee on Quality Assurance.
yeah, I always want to say, I can't ever say if it's committee or conference or whatever that committee is. So it's an accreditation agency, and they have a stepwise process to make sure that you're doing a bunch of things that make you, follow best practices, right?
So if you get a higher payment if you actually meet their standards, is that correct?
You
That's how I
put from the
understand it.
insurers.
What's that?
The insurers, some insurers do pay you an enhanced payment because of your PCMA status. But you don't automatically get it. It has to be sort of a program of the insurer or the payer.
Yeah, NCQA doesn't have any authority to.
No, not NCQA, but I meant it meeting those criteria.
It could be utilized to use an
Yeah.
incentive
Yeah.
to, for higher, yeah.
So the way it was,
Recently,
I
she
thought it was
suggested to
tied,
me-
I thought there was something tied to it at one point, but anyway, that's there.
yeah, the way it was built originally here was, think of it this way, everyone's doing their own thing, onesie and twosie docs all over the state and all over the country. But when we stood up the blueprint, we said, hey, first, before we can, if we want to move along the value from fee for service to value, right? You have to first make sure that the clinical folks have the tools they need to understand what the best practices are, have the right EHR in place. We didn't even have the EHR program back then, right? So all of those things have to happen before you start saying, okay, now you're going to have upside downside risk. Now you're going to have full capitation. In order to move along that continuum, you have to provide the tools. And so one of the ways to sort of set a bar was to say, let's get you NCQA accredited. Let's give you the tools to get there, right? Before we start giving you other requirements, pluses and minuses, let's get there. Today, it's in almost 2022, right? We're mostly there. And the folks that aren't there have had a long, long time to get there. And so I just want to put a pin in that for a second. We'll come back to it, okay? So on slide 37, we are talking about collaboration here. And one of the things is the last analysis we can find is in 2015 of different care management, care coordination, chronic care management programs around the state of Vermont. And there's a lot of different programs out there that were designed for different reasons and staffed by different people. And again, to the extent that we have programs, we should have a list of them. We should know who's in them. And if some of them are not performing as well or not as useful as they used to be, then let's rejigger stuff, right? Let's figure that out. And so we believe that inventory should be updated and can be updated and should be that should be done, and that we ought to look then, once we have that list, to get some common definitions in Vermont for what care management, case management, care coordination are, so that we can compare those programs and make sure they're staffed with licensed professionals appropriately and all of that. And so that if you're a consumer, you could look up the one pager on it and know, like, oh, I'm getting case management, that means this. There's a lot of transparency that happens when we do some of that collaboration.
Can you say that the last inventory was done by whom?
It was done in 2015, and was that done by the agency? Do you know? Or was it?
I think it was like the SIM grant, it was part of that.
Yes, okay.
Yeah.
So we have a link to it, and it's
how
in our,
many of different programs were there then?
a number. I don't know the number.
Right.
We can pull that out for you. So, but yeah, a number.
Is
quite a
there
few.
is there a link to that report?
There is. Yes.
Can we get that link?
Yes.
Yeah, it might be, yeah.
Yes, because when someone says integrated care management to me, I think of something completely different from somebody else. Sure. Yes.
So moving towards a common reporting process for identifying gaps in care and avoiding duplication of services. That's a standard practice for care coordination, but it's not dumb, and we don't have a common way of reporting it, so we know again what's happening across the state. And again, this is just a coordination activity, and then conducting that consistent ROI analysis. So those are things we believe could and should be done today to improve the state of our care management and to improve the efficiency and effectiveness of the Blueprint for Health. Slide 38. So we took a look at some CMS reporting, and this, I guess you call it a meta-analysis, looked at a bunch of different programs and identified that there are some specific intervention components of a care management program around behavioral health, telehealth, and information technology that are valuable, that are quite valuable. And that there are some program design and organizational characteristics that are also quite valuable from a estimated cost and their quality outcomes. Prior experience implementing similar programs, targeting patients with substantial non-medical needs, to our SDOH comment, focused on individual patient care rather than transforming provider practice. I'm going to pull the pin out now of the Ncqa thing and say that we know that we needed past tense to transform provider practice, and that although practices still need support, that transformation must needs have happened already, by and large. I am certain that there are some providers who will disagree vehemently with me, and that there are people and providers and practices in different places and different states. And there are some instances, for example, where they implemented an EMR or EHR in their practice, and now they're implementing their fourth one, and they're going through their fourth round of practice transformation. And I sympathize with that. But from a state policy perspective, those dollars could, and I would say perhaps should, be redirected at this point. Not necessarily outside of primary care. Maybe they should go to rates in primary care. Maybe they should go, overtly to rates in primary care. Maybe they should go to support additional members of those those community health teams, right, that are supporting those primary care practices. But that discussion, and again, I don't want to design the program. I'm just pushing out the options here for how the blueprint could be pulled forward. And I know that there's a new executive director, I believe, who doesn't even start until January. And so I am happy to be available to have conversations with him when he starts, should he want to, and certainly am not trying to impose direction on the new director. But I think it's important for us to think about it from a policy perspective at the legislative level.
Each one of the 4 bullets that you have there are, I think, we have talked about in different ways, but are really pretty critically important to move forward.
Yeah. I think we thought they were right on point for the conversations that Vermont is having now, and for where our health system is as far as along its path towards transformation. Slides, I'm gonna jump through slides 39 and 40 and 41 here very quickly, just to say that we want to talk about other states. I believe you've already heard some stuff about Maryland and their total cost of care all payer model. Certainly we could have more conversations about lots of different parts of it, but the bolded piece here, that they use data from lots of sources, including claims and publicly available data for risk stratification assignment to care, lines up directly with our recommendations here. When we look at the Washington primary care transformation model on slide 40, we see, first of all, the model is targeted for implementation, right? It hasn't been implemented yet. So it's, again, not surprisingly, look at Washington, look at Oregon, look at Vermont. These are states that tend to be pushing harder and faster than other states in the healthcare arena. And so they are good peers for us to look at, even though they're very, they're much bigger, of course, than we are. Even Oregon is bigger than we are. But again, I just want to point out, and we're doing some of these things, right? Aligning payment incentives across payers, right? We're doing some of these things and checking that box every time. How aligned are our payments across payers for specific services? And if they're aligned as they are in paying for the CHT teams, are we demonstrating value, right? Do we have a way to draw the line between I'm making a payment and I'm getting a value from it? And your payers are definitely focused on that. And so we should be also. So that's all I had to say on that one. And then finally on 41, and I'm just trying to move a little bit quickly because I want to get to the summary slide before we turn into pumpkins today. The comprehensive primary care plus model is an interesting one to think about, right? So done nationally, 2,600 primary care practices across the country, lots of reports on this, lots of information. Just wanted to pull out a few things. One is that multi-payer payment reform is critical, right? And when you think of practices that are dealing with lots of payers, and you as a payer, as Medicaid or Medicare, have 15% of the practice or 40% of the practice, that's still not enough. That's still not enough, right? Because they still have however many other payers to deal with, and workers' comp besides as a payer, right? Like, don't forget about the smaller payers that they have to deal with, different paperwork, different incentives, and all of that. And so the more we can align things, that's really valuable to practices, and especially valuable to small primary care practices when we align payment reform. And when we provide that data feedback. So what is the feedback to those primary care practices as far as how things are going? Doctors are driven by data. So when they get data that compares them to their peers, they react to it. They change, they hold team meetings. They don't want to be the worst in the cohort, So when we detail doctors, remember counter detailing on pharmacy stuff way back, that's impactful, immediately impactful.
It's still working.
Of course.
Yeah.
They basically said we're all type A's and none of us want to be the one that's the outlier.
That's right. That's right. That's right. So these are, and then learning supports. And so as we make changes, as we pull practices from fee for service to full capitation, each step along the way, we have to provide the opportunity for folks to learn before pushing them off the cliff, right? So that said properly, it's memorable anyway. So, and then I would say that we have a health information exchange vital in Vermont, and again, we shouldn't forget that we have massive more capability than we had 5 years ago, 10 years ago, massive more capability to inform practices and to provide information to payers and to Vermont state government to support transformation. And we have boots on the ground. Vermont has all the pieces necessary, right, to continue to push that transformation forward. It's just a matter of identifying what to do right now. And so that's what we've tried to do here. And that's,
well, and you brought up Vital, and Vital actually is what has taken our healthcare world through the pandemic. I mean, and through the cybersecurity breach that occurred, but some of the practices could not have survived without it. That's what I've heard anyway, when I've talked with them.
I believe it. So I don't know if there's questions or discussion on the blueprint stuff.
There's a huge amount, but I'm thinking that we probably should keep taking steps forward.
I can go right to slide 43, which is our last slide, except for the thank you slide. So what we've pulled together here is a slide that summarizes everything we talked about today. And really, it's over summarized, so it's missing lots of detail, of course. But it's a nice one pager, I hope. So we talk about what the option is down the left-hand side, and then who's served, which Vermonters are served, the estimated number of the Vermonters that are served here, the key advantage of each of these programs, the expected time frame, and then importantly, for this last conversation today, the alignment with other options. As we've thought about as a team, the different options here, they're better together. They work better when you combine them, right? It's a sandwich tastes better when you put all the pieces together as opposed to eating those pieces individually. We're not recommending that you do all of them immediately, right? Like that's not, we don't have that type of recommendation. But we do recommend that you think about them concurrently, and that you envision how a cost growth target, as Beth said at the beginning of the day, overlays all of these and both supports the initiation of a change, perhaps in the blueprint for health, like we talked about, of adding some things and providing some tools and shifting around some dollars, and that then in a nice little circle, doing those things to the blueprint supports the cost growth target, right? These things are directly connected to each other in tangible ways, and so. I'll stop there because you all can read, and I've been talking a lot, and so I'm happy to conversation or whatever, wherever you want to go.
You were going to mention something that I had been sort of bringing up every time wanting to take a look at the Medicare Savings plan, that cliff.
Yep. So we have had a conversation about the Medicare Savings Program. We are going to put together a fifth option paper in the next couple weeks on that program. For those who don't know, that program operates in Vermont today. It supports Quimby's, Slimby's, and QI1s. Those are all, it's just fun to say that. So it's really geeky, but those are individuals who are Medicare eligible and partially eligible for Medicaid, that they receive support from the state of Vermont to pay their Medicare cost sharing and Medicare premiums for Part A and Part B without an asset test. So it's a small group. In those three groups, there's about 2,000, just over 2,000 people in each group. There's 6,500 to 7,000. I don't think it gets to 7, but 6,500-ish people in those three groups. And Representative Donahue has asked us to take a look at if we offered those benefits to more people, to increasing the threshold at which individuals, income threshold at which individuals could receive that benefit, how many people would be helped and how much it would cost. Is that, I guess,
because right now that subset of people fall off a cliff. They are getting Medicaid benefits up until they get on Medicare. They're not eligible as dual eligibles, so they lose the Medicaid supports they were getting, and they are very low income. They're I think 100 to 135% income, and all of a sudden they lose those benefits. So they
Because they have assets.
No, because the income level changes.
if they go to 140, if they're a QI1 and they get to 140, they're off of that. They're off of that benefit, which is worth about $226 a month on average. So it's not insubstantial at that income level, right? It's substantial at that income level. Understood. So we're want to recognize we're going to do that analysis. We'll produce that paper. It doesn't fit in any of the other papers, and so it's not in any of the other papers, right? Because it's a different thing.
Pretty discreet.
It is very
Yeah.
discreet.
Okay. Any thoughts that you have on, obviously, I think the blueprint offers a lot of opportunity, particularly for the moderate needs expansion piece and moving those folks in. I also question how we could just categorically move primary care, all of primary care, and as in the blueprint model. I mean, because right now it is a chronic care initiative, and we look at kind of the other end, but if we look at the prevention side of primary care, just a question.
So you mean to have primary care payments run through the blueprint?
Yes, and a healthcare team in place for purposes of maintaining health, prevention.
You lost me.
Yeah, me
Back
too.
up, back up,
Okay.
because you've lost me. So whether it's a question or
That's my question.
Or proposal.
Could we move our primary care practices into a blueprint model? Does it make any sense at all? Because in many ways, the current blueprint is a primary
I just
care
say
for
they're
folks.
already primary care.
Yeah,
right?
well, but they are folks with cardiovascular disease or diabetes or other chronic issues. And so if you look at that, that's not really primary care. It's primary care for someone with a chronic illness. So it is really more of a step up in terms of specialty care. So is there a way to look at primary care through the health team model? Does it make any sense in terms of prevention? And going back to the earlier conversation from Clarify Health regarding social determinants, certainly that becomes, if you're working with a pediatric set of practices and you're looking at kids and what possible issues within social determinants, whether it's housing or substance use disorder by the family, and trying to expand that primary care.
So I'm trying to follow exactly where you want to go with that. I think.
I don't need to go anywhere with
Okay.
it. I'm just raising it as an issue and whether or not it's something that we might want to consider, because we have here 600,000 Vermonters paying premiums, and what are the health outcomes for those folks? So how can we put them into a system that offers savings while maintaining quality?
Yeah, so I think the blueprints is very supportive of primary care practices. I don't know the number of primary care practices that don't participate, but it's a very small number that don't participate in blueprint today. One of the things we don't know today is how many individuals from each primary care practice receive blueprint scheme supports and what supports they receive. And I think that type of information would be very valuable in identifying the value to primary care practices. And the level of the differential, what I expect to be, in fact, differential support for some practices who use referral to the blueprint teams much more than other practices today. And that type of information would be very helpful to those primary care practices who perhaps are not referring or are certainly not referring at the same level. If we could connect outcomes, improve better outcomes to those practices, thank you guys, to those practices that are making more referrals as a percentage of their total patient count to the blueprint, that would be that would have an impact on provider behavior, I guarantee. And on the value case. And so that's a good example of how we could use more information about what's happening today in a critical way to drive improvement, practice level improvement.
So the missing column on the
Yeah.
sheet here is the cost column.
Yeah.
But I guess to me, a broader, the more that we've moved along in our discussion, we're really looking at health systems improvement that hopefully will improve cost, which we've been working on for years, for better or for worse. And it calls to mind for me once when a few years back, when the administration was responding, we were looking at questions of affordability, and the all-payer model was being presented. And there was this very upfront statement that they made at the time saying, the all-payer model is not intended to increase affordability. Lori's remembering this. It's intended to bend the increase in cost and to improve quality. Not intended, except as a secondary effect. If you bend the cost, maybe you're helping with affordability. But if it's already unaffordable and we're only reducing the cost curve some, we're not making it more affordable. And I feel a lot about where we are right now. This is not what I envisioned when we talked about affordable, accessible care. It's not about, of course, a part of it is always about improving our systems to be more cost efficient. But it's not really helping with affordability for those groups for whom the biggest challenges exist. And I guess that's one of the reasons why from the beginning I've kept raising the Vermont Savings Bank, because that is a group for which we know very specifically have an affordability gap. And these are all good things, some stronger than others. I think they all will help move everything we've been trying to do forward. But it doesn't feel to me like this is a strong outcome for us as a task force in terms of affordability for Vermonters. And I wanted to add, and nor for when we talk about equity, and we just talked about it helps get healthcare to everybody equally, it doesn't address, it's obviously not necessarily intended to address health disparities, but to the extent that part of our mission was to incorporate health disparities. This doesn't really hit directly on that either.
So where I'm at is that if you look at these and you're able to look at, say, a 3+ year, let's just say a 3-year horizon for bending the cost curve, well, we're also looking at a 3-year horizon for spending quote unquote one-time funds that are coming from the federal government. And I know we're not appropriations, and I know there's certain eligibilities for those funds, but I think a lot of people, a lot of legislators are coming forward with investments that they want to make that might fall under a blueprint, particularly. And is there a way to say, this is the way we're going to invest in a better system and better care over the next 3 years that will be on a financially sustainable path, because we're measuring our return on investment, we're measuring bending the cost curve, and we're sort of bridging into a better healthcare through a strategic investment of some of these dollars that are coming to us. Does that make sense?
Mm-hmm. That will be an important conversation during budget adjustment and then going forward, hopefully when we see Build Back Better. But I want to go back to something that Representative Donahue has said. And I look, for example, at the moderate needs. And then I think about the demographics that we have in our state and the long-term care needs that are coming upon us. And I do think that being prepared for that deluge and trying to provide services for folks who are getting older and wanting to stay at home. I mean, this involves a whole host of institutions, nursing homes, residential care facilities, and others, and Choices for Care, SASH, are all of these programs that we have in our state that are so critically important. So for me, I think if you just look at that little cohort of people, and Josh, you explained how it could be more or than that 18,000, or it could be less, it depends. It all depends who breaks their leg, or both knees at the same time, as my husband did a couple years ago. So yeah, oh yeah, that like we can talk about home care sometime. But the point is that we're not going to do the broad stroke. I don't think we're doing the broad stroke with this task force, unfortunately for some people. But what we are doing is we're identifying some areas that really need improvement and that will help people afford the care that they need. So, and some of it isn't expressed specifically here. So we talked about primary care quite a bit, and I think we're going to come back to that. At least our committee will in the Senate. The other area, the long-term care, for me is very important, and we'll be talking about that with you in healthcare and with human services in the House. And then trying to sort out how we can improve the blueprint going forward. We don't want to see it stay stagnant, and we do want to see it increase benefit. And I would think in particular for the hub and spoke program, which is so critically important, and we're seeing an expansion of need within that program, especially during the pandemic. I know, so I think there are some great things that are identified here, but it's going to be incumbent on us to really put together the specific recommendations that will take it forward. And I'm looking at Josh because I know we talked about what possible legislative recommendations can you bring to us as we're, and I know Nolan and Jen are listening and they're going to have some ideas, but that will help us to elaborate further on these proposals, because we're steps ahead in some ways, but we're steps behind in others, depending on the state you look at. And we haven't even talked about global budgeting in this committee, because that's in another committee. But so but I do think there's a lot here. I'm quite excited about the possibilities. So I'll disagree with Representative Donahue, but we will continue to work together.
I mean, to the extent that that some of this, supports and could expand and make it more integrated, what we're already trying to do with the accountable care organization, and yet that's staying much smaller than to the extent that this is infill and improvement to that. I think it's a gain, and I'm not saying these aren't gains. I just worry about the people who are being badly left behind.
We are going to let that happen.
Right
We're
now.
going to grab their little hands and pull them right along. We want to help.
I just have, Senator Weston said something in the beginning about business and healthcare being a business. And I remember when my husband was diagnosed with cancer and we had to go get a second opinion, our oncologist said, you need to treat your second opinions as a business, and you need to go, because they're looking at you as a customer. So you need to look at them depending on where you go. And one thing I think I've walked away from through this whole process is we look at the individual players in our healthcare system as businesses, but I don't think we're looking at it as a business system. And return on investment was throughout this whole presentation. We had never talked about return on investment in committees. At least we haven't. And so just to know what, look at blueprint, it's great, but there's probably so much there that we could look at if we're looking at it truly as a business. And that's where we're going to find some savings to potentially do some of these bigger things. I mean, I agree with Representative Danu and Senator Lyons. I'm disappointed and I'm excited at the same time. You know, it's like this conundrum we have here. But anyway, that's what I take from it. We have to start looking at the system as a business.
Oh, sorry. Well, to that point, I think I was on a call, I think with H. Weller, Living Well, and we were talking about care management, and I kept saying it's really the care economy, right? Like it's a huge industry. And that continuum of the care economy is making a lot of other states a lot of money, you know, while providing a lot of options for older Americans. And I feel like we keep calling it care management, you know, for those who sort of like are on the fringes or something. And it's a really huge chunk of the population that has this you know, range of income and just need better coordinated care. So I would agree with that. I also just wanted to say, I don't know if it's to Anne's point or not, but when we talk about understanding what's affordable and who's underinsured, I think tailoring a public option to those most underinsured is still worthy of consideration. I just don't think we got a surgical enough understanding of who that largest chunk of the population is that's underinsured. It sounds like it's people in the small business market. It sounds like it's okay if it's young people, you know, they still, you know, are underinsured at a time when they want to have kids and buy a house and do all those things. But I just wonder, before we end this work, if it's possible to set ourselves down a path where we better understand who, I don't know if it's 35,000 or what chunk of the population is significantly underinsured, and how we get a public option that makes their healthcare much more accessible and affordable.
I think we have that data, and I know that
Okay.
you know, Nolan and Jen can pull the reports out for us. That there are no list of reports that we've had in the past, but it does help understand who is being affected. But then remember, as we said earlier, there are some who will never be insured. So even if they're underinsured or uninsured,
Even like the 3%.
yeah.
Yeah.
You know, and Anne was just asking, but we're in the midst right now, I think, of the household insurance survey.
Mhm.
In fact, our household got a call one day. And I said, yeah, we need to answer that. We don't always.
One of the few surveys.
Yeah, but, and so we've data from, you know, several years back on that. But I also think if there's a way to think more precisely about underinsured as opposed to uninsured, in terms of some of this population that we've heard over and over from Healthcare Advocates Office and others about that's one of the places where people experience it, especially if they're paying high premiums but can't access the actual insurance. And I still need to understand that better as to whether we're asking for apples and oranges here or not. But I think that's a place where, to the degree that you were all able to help us look more precisely at that, whether it's the public option or how to, if there's a way to target some of the assistance to that group of Vermonters, I would find that very, very interesting and potentially helpful. I guess I just want to say that, you know, I came into, you know, when we narrowed this down to these 4 ideas to go in more in depth, it was pretty clear to me from the outset at that point that this was not going to result in some significant immediate affordability. And so I'm a little less disappointed because it's what I expected. I kind of had the sense that that's where we were heading.
Well, right, this is not like a sudden news.
Right.
Yeah, I'm just gonna say, I don't think it should be a revelation.
No, it's just kind of been my.
Well, yeah, well, but I
Yeah.
just wanted to acknowledge that. I think that's where we actually set this in that direction.
Understood.
And so I think we need to we need to both own that and acknowledge it and see what it is here that we can take and use, because we have a kind of analysis that we haven't had before, as some perspective. And so the question for me is how and if we can take pieces of this and use it to move forward. And I'm not just going to say on affordability, but to move forward on accessibility, affordability, and quality
Equity.
and equity. And we know that, frankly, anyway, we have other initiatives underway that are also looking at health equity. We have groups looking at that. Our job is to take this, not just this report, but to take all the different pieces and see what we can synthesize and hopefully continue to move forward. And one other piece I'd say that I personally, I mean, there have been some, and I think there still is in hand, some immediate affordability issues. And in terms of the extended premium tax credits, which frankly, I feel like we, apart from the work of this task force, we need to look at what is it that, how successful have we been in getting Vermonters to access millions of dollars that are on the table.
Yeah.
And I spent some time with Sean at DEVA trying to understand that. And I think we ought to be talking with our insurance companies, because I've heard that it's as low as 12% of Vermonters have actually moved their insurance to get access to the new premium tax credits. That is, if that's accurate,
It's ridiculous.
that's a lot of money being left on the table for Vermonters who have money that they could be saving right now.
Yeah.
Some of it's significant. And so I think, again, for me, it's like, we have all these different items on the table. That for me is something that's a priority as well. And that doesn't take 12, 18 months to implement. We should be finding out what is still possible for Vermonters to access those dollars, because they're immediate. Anyway, so.
And we need to do that soon, right? Because it has to be before they pick their plan.
Well, and some of the, I think that deadline was today.
Today is Medicaid, right?
For effective for January 1st.
Yes,
And then
right.
January.
But I think they're allowing through February.
Yeah. So, but I think that's just something that I think is.
That's something that we haven't researched necessarily, but it is certainly something that can be done probably by directing one of our agencies to put together a system for information. And
We need to hear what they've done and say this, what is it that we can do to be doing more? Because I just kept saying, we've got to be doing more.
so I think Senator Westman had a question.
Sorry.
No, I just had a comment.
Oh,
Feeling like the old man at the table. I sat at a table just like this, and we met mostly in 9/11 in the early 90s, 3 decades ago. The first attempt to do universal health care coverage. We've never been very successful at doing wholesale change. Everything has moved us along in those 30 years is incremental, and it's put us in the place where we're at the place where it's 3 or at the bottom of the country or the top of the country, whichever way you want to look at, in the uninsured, and I think we've done quite well. I do think for those moderate needs people, or those people that are in that middle category that are, I think, are mostly young, that have an insurance plan, that's the next place where we need to focus on. If anything, the group has done for me, and I'm not sure it's the way to go, the discussion about what we, and it's not particularly your bailiwick, but it is your committee's bailiwick. I think we have a tsunami coming when it comes to people in long-term care insurance and all of that. And I think for me, what you've done is you've highlighted that, and I'm not sure your direction is the right way, but I think
that's why we have committees
yeah, but
and appropriations.
I get it, but I mean, you know, I think I really think we need to spend some more time on it, and are glad other states, particularly out on the west coast, are doing it. But you know, incremental change is what the name of the game has been here for 3 decades.
And it will be. It will be. And I think we need to not fall into the idea that this committee or any committee is going to come up and implement a wholesale up and down change in a system that's going to suddenly turn it on its head. It's not. I don't see that as in the works at all. And I was saying to somebody, I think middle of the night last night, I felt like I had to, like, you know, we have spent years, the past number of years, 4 years, just until this recent year, fighting off attacks on the entire healthcare system. And I'm just going to be candid, that's my view. We fought off national attacks on the Affordable Care Act and the healthcare system. We've had barely a year of a new administration trying to get its feet under the ground in a completely divided nation.
In a pandemic.
And exactly, thank you. And on top of that, doing all this in the midst of a tremendous pandemic that no one could have dreamt of. And so I think we really need to be thoughtful and realistic about what it is that's in front of us and how to move forward, because we have not been working with alignment on making major change, and we're still not able to work in full alignment. And we're still in the midst of the pandemic, and our system is stressed.
Big time.
I just want to say one more thing, because I think I had the strongest reaction when I thought about how detailed the data could get from Clarity. And it was, you know, it was billed as sort of ROI, but in an investment in that level of precision around health equity would be, I think, incredibly game changing. Just when I think about how much we attacked the COVID disparities and realized that they were significant when it came to limited
Data.
English, like I'm the one always asking for data, so I didn't want to be the one to, you know, like throw cold water on that presentation, because that understanding, I know you know, I'm in communication with communities who would love to be able to know and hold accountable a system to closing disparities all over the map, their geography, age, race, it's limited English proficiency. So I really do want to know the answer to that question, because that's a huge area of disparity.
It is on their list in the handout.
It is?
Yes.
Oh, yeah.
I think the question
As one of their
about how
examples.
folks- Yeah, I
Yeah.
think the question is that
Can you break
data
it
is
out?
pretty iffy sort of across, so sort of how much they're able to do it. They are able to do a lot sort of at the zip code level,
Okay.
and sort of even at to the extent they have an address sort of within a zip code level, to say that like this neighborhood is predominantly speaks this language.
Yeah.
So that even if they don't have sort of personal information, they're able to.
Well, and
Page 24, column 2.
Percentage of population of limited English. Okay, I missed that. I was looking at the little one up there. Okay.
And within the limitations of, like, one of the things we looked at as we were setting up the Health Equity Commission is that data is not always good data,
That's
and it's
right.
not available data,
Mhm.
and it's not collected the way. So
Yeah.
we're, you know, we simultaneously have work being done to try to help the whole system, the whole healthcare system, get its data
Right.
where it should be. So, but working with what we have available, I hear you.
Yeah.
Yeah, so, and during the pandemic, early on, we asked the Department of Health to begin collecting that
Right.
information.
Right.
Now they're doing that. The Health Equity Commission is currently working, will be bringing us their report, probably not until February, but it will inform whatever we do with this information. So, and there's a lot going on. We haven't talked about the remote piece. And we haven't talked in depth about prescription drugs, but we know that's going on. So those things may well keep money in people's pockets and make it affordable, both in terms of all kinds of resources, whether it's financial or transportation or which translates to financial, doesn't it? So, yeah, the charge that this committee had was pretty clear, and we have sorted through that, and I think our consultant has helped us to respond to the charge effectively. I'm not, so I'm looking forward to the next step, which is what will the final report look like, and then how we can use that in our respective committees. And just to say that I know that the Health and Welfare Committee and the Healthcare Committee and the Healthcare Committee in the House and Health and Welfare in the Senate will very definitely be working together on in the session, so we can get our arms around what recommendations we'd like to move forward with. And it'll depend a whole lot on what bills we have in our committees and how we can take those and expand those a little bit. So, but I don't want to go without saying thank you to Joshua and Beth and others who have been extremely diligent about bringing us the information that we've asked for.
And I'd also just like to echo your statement. I know you've met with a lot of stakeholders in our agencies and thank them for their time as well.
Became a senator and a House member.
I'm sorry?
He became a representative and a senator.
I did?
No, he did. Joshua did. He meeting with all the stakeholders.
Yes,
Right.
exactly.
Well, I'm looking for us to lay these recommendations on the table without making a prioritization at this point.
Yeah.
Lay them on the table of our two committees and include others like human services as appropriate and necessary, and then to be able to circle back and
I would say, I think human services in that house has to be included.
oh, absolutely. No,
Yeah.
they do. That's what I was
That's
trying
their-
to say earlier. This absolutely is an important piece for us to bring them in to be part of it.
So I know that I'd like to bring us to wrap.
Yeah, like
It's
that's
3:30.
where I'm at.
And I know that the healthcare advocate had some information to share with us, but I'm going to ask that we put that off.
Oh, yeah, no,
Please,
yeah.
there's just no way we can
Yeah,
do
no,
that. And Joshua, next steps, you'll be in touch with us.
Yeah, just briefly, I would say the next steps are, we're gonna do that MSP paper. I think of it as it'll be a shorter options paper. It's a pretty discrete
Yep.
piece, so the explanations, the description, and then the numbers, pretty straightforward. And then we'll do a summary of these. And these options will be the chapters, and there'll be an executive summary essentially at the front end. We'll pull some of the stuff from the slides, the tables and things to help to create that summary. And then I'll send it around for red lines, comments, conversation. You can give your comment, you'll be able to give us set a meeting, give us your comments, send them to us via red line or however you want. And then we'll create a final after that. So there's be one go around, so you have a chance to say, wait, you're missing this, or you're not emphasizing that, and that's important. That will give you a document inclusive of all the appendices and everything else that you can lay in front of your committees. We'll also produce an update to this presentation, a different presentation, but we will again use some of the summary slides and things like that, but not all the heavy text. For a brief slide deck that could be used, that we can use to present for you or with you, or you could use to just give to somebody so they could get a feel for what we have here. And I want to say, this has been a fun project for me personally. I haven't delved back into Vermont in a big way in a long time. And I know for the whole team, we got to talk about, it's fun to work with Vermont on healthcare because Vermont is in the front end, and that we were focused on staying in our lane and making sure that we put incremental builds on top of what was there, not like some wacky new thing. And so I get the process and I respect it. So I know that there's a lot of other players that have influence on where we come out the other end of the legislative session. So I look forward to seeing what happens.
Okay,
Thank you.
thank you all. And we will get to back together, I think, early in the session, just to say yes or no,
And the
vote,
final report.
final report. So we'll set that up.
And I think we talked about having a presentation to our joint committees, and maybe at that point, we should
Yeah.
try to make sure it's the joint committees or
Yeah.
talk with Representative Pugh and see what makes sense in terms of involving their committee and having the whole task force. members
Yeah, I did
part
talk
of
with
that.
her about that.
But you're gonna say, we're gonna spend New Year's Eve.
And you're gonna. Okay. Anything else? Thank you all.
Thank you.
Thank you.
Thank you.
Right before the weather gets too bad.
Yeah, it's coming soon.